Hi all of you, all those who have attended the NEET SS 2025 session for MCH surgical group, and we are going to discuss those questions which are asked, and this is given, all this are by from the students who have written the exams or from the internet resources, where we can find questions similar to that. May not be the exact ones, but we'll know the areas where they've been asked. So let us try to go into it and see. Before even go into it, let me tell you that this paper is of a moderate difficulty, and these questions are 80% asked from Subistant 22nd edition and almost close to 20 to 25% maximum from Bailey 20th edition. As I go on with the discussion, you will be able to clearly identify where exactly these questions are picked up from line to line, and so that you will have an idea to prepare for the next exam. And also I want to tell you, as in Speed Learning app, we have done the Subistant 22nd edition and Bailey 20th edition and Schwartz 11th edition line by line discussion of the MCQs. All those students who did the course in Speed Learning app for general surgery or the PG exit standard for NEET SS general surgical group, all of them have got an amazing result and a good rank and the specialty of the choice. So they will be going on to the institute of the choice also. So with this, I'm telling you the kind of the work that done by the entire faculty of Speed was amazing. That you can also refer to the students and the interview. I have taken multiple interviews that is available in the YouTube in Speed Learning app channel. So that will give you a fair idea that how you need to go on with the preparation in Speed Learning app. Okay, let's go on to the question number 1. The question number 1 of NEET General Surgery SS MCH General Surgery Recall, and these are the reference from 22nd edition of Subistant, 20th edition of Bailey and 11th edition of Schwartz. Corona mortis lies near which of the following structures? So this is the question which has been discussed in the class already, and the right answer is retropubic space. And for all this reference, I have taken from the class notes itself. Now, for you to a quick idea, it is given in Subistant 22nd edition, page number 1087. Now, corona mortis is a vascular anastomosis between the obturator vessels and the external iliac and inferior epigastric vessels. It runs over, number 1, the pubic ramus, number 2, behind the pubic symphysis, number 3, in the retropubic prevesical space. In the retropubic prevesical space is also called space of Ritzius. It can be asked in the next exam as well. So it's a factual level of question. Then you need to know it's a retropubic space. Now, question number 2 reads, failed POEM procedure, next best step in the management of this patient. See, POEM is a procedure. Per-oral endoscopic myotomy is a procedure done for achalasia cardia. So, when it is done for achalasia cardia, you know the procedure that an endoscopy is done and a mucosal opening is made 10 cm proximal to the OG junction. Then a submucosal tunnel is created and the division of the muscle, of longitudinal circular muscle, happens at the level of the OG junction, at the level of LEA sphincter. Now, this is today is been set standard for most of the patients who are doing with an achalasia cardia, most often it's a OPD procedure. But the question here is, when if it fails, what do the next step? The next two is a laparoscopic Hellas myotomy with a partial fundoplication. Okay, is that clear for all of you? Now, Subistant 22nd edition, page number 1116, it says initial treatment. If the initial treatment is POEM, because in this question already POEM is done, and pneumatic dilatation, or a repeat POEM, or a laparoscopic Hellas cardiomyotomy. Now, what you need to understand is, this can be this way. A patient could have been a pharmacological treatment of smooth muscle relaxants, or could be a endoscopic dilatation or botulinum toxin. If all this the patient have tried and then move on to POEM, okay? And if POEM fails, what next? The POEM fails, the next best will be laparoscopic Hellas cardiomyotomy. So laparoscopic Hellas cardiomyotomy and also should be used depending on the expertise of the center. However, if POEM was performed on the anterior wall of the esophagus and the stomach, and laparoscopic Hellas myotomy might be very, very difficult. So again depends, POEM, which wall is being divided. Muscular wall is divided, myotomy is done in which wall. So that makes the subsequent procedure also easy. But those details which are not there in the question, but you need to have that in the mind. An elderly male patient in ICU develops an intractable diarrhea on the second day of admission. The most important point here is the intractable diarrhea. Now, lab reveals leukocytosis and thrombocytopenia. What is the mostly diagnosed? It's a straightforward and a simple question. The answer is Clostridium difficile infection. Now, try to understand, symptoms of CDI commonly begins in 4 to 9 days after the initiation of antibiotics, but can commence up 10 weeks or more after antibiotic treatment. Patient presenting with a new onset, see that, new onset, unexplained and watery diarrhea, 3 or more unformed stools in 24 hours should be suspected of having CDI. Patient may also have abdominal pain, fever and associated ileus. So page number 1474, subsistent 22nd edition. Okay, so the most likely organism is Clostridium difficile. Clear? Okay, next. Circle of Willis, this image was given, and what exactly the question was asked, I don't know. I believe it would be an aneurysm, barianeurysm, the location of barianeurysm. That's what I heard. Now, if they ask you the location of barianeurysm, then in that situation, you will have to know it is about the, number one will be the junction of internal carotid artery and middle cerebral. Yes, and the second most common location will be anterior cerebral and anterior communicating. And the third location could be around the middle cerebral artery. Okay, so in case they ask you all the 3 junctions of the most common location, it could be of internal carotid artery, middle cerebral artery and the posterior communicating artery, and to an extent the anterior communicating artery. I'm sorry, anterior cerebral artery. So I'll repeat this once again for you. If the junction is asked involving of the most common location of barianeurysm, it should be internal carotid artery, middle cerebral artery, posterior communicating and anterior cerebral. Okay, so this is what is about barianeurysm. They can ask you the most common cause of subarachnoid hemorrhage. The answer is trauma. The answer should be trauma. If they ask you, the second most common is barianeurysm. There could be an underlying barianeurysm as well, and trauma could be the precipitating factor. Okay, thunderclap headache, the worst headache of patients experience the worst headache in life, thunderclap headache is subarachnoid hemorrhage, and the prognostic scoring scale is Hunt and Hess. Hunt and Hess. Image of a posterior urethral valve was given with the distended bladder was given. What is the initial step in the management? See, the initial step in the management of the distended bladder is to catheterize. When you look into the catheterization, the only one option is available here is a suprapubic cystostomy. Now, always the posterior urethral valve is one of the most common cause of obstruction of the urethra. Yes, and to have bilateral hydronephrosis. So the posterior urethral valve, the most common location is just below the vermentanum, and it is a fold of mucosa, acts like a valve. It allows the passage of a catheter, but not the urine. Now, of the drainage available, suprapubic cystostomy is the drainage is what is available right in the question. And then what you do is, once you could decompress the bladder and also the upper tract, once you decompress the bladder and the upper tract, then you can do an ablation of the valve. You can do an endoscopic ablation. You see that definitive treatment involves endoscopic ablation of the valve. Okay, or endoscopic fulguration of the valve. Clear? Great. Now, which coronary anomaly would produce a murmur similar to PDA? It's a simple, straightforward and MBBS level of question. The right answer is a coronary AV fistula. Clear? So, it's called the medullary murmur. So, PDA produces a medullary murmur, and also a AV fistula will also produce a medullary murmur. There's no need of explanation required. The continuous flow from a high pressure of artery to the low pressure of chambers throughout the systole and diastole. It's called continuous medullary murmur. Okay. Next. Mammographic image shows a popcorn classification. The popcorn classification is a typical feature of a fibroadenoma. One of the most common benign tumor or the benign lump in the breast. Popcorn calcification. Popcorn calcification in the lung, suppose they ask you, it's called hamartoma. So fibroadenoma is also called a breast mass. It can be diagnosed by an ultrasound and also by an FNAC. Clear? So one of the most common cause of a breast lump, benign in nature. Okay. What is the most common cause of death after bariatrics? A very, very, very important topic and a question. The answer is pulmonary embolism. So bariatric surgery is done in morbidly obese patient. Okay. Pulmonary embolism is one of the feared complication after any form of bariatric surgery. Understand, this is given in page number 1573 in 22nd edition of Service Standard. Clear word to word, line by line. And further information I have given in the slide, you can go through that. Now, which of the following is a false statement in lymphoscintigraphy done for lymphedema? Now, there are various options which are available to differentiate between primary and secondary lymphedema. It has a small exposure of radioactivity, migration of a radiotracer within the skin and the subcutaneous tissues, monitor the whole body gamma camera. Edema, secondary to the venous disease or isotope clearance, is usually rapid. Try to understand. The answer is option A. Because if you want to differentiate between primary and secondary lymphedema, you need to do a lymphangiography, not lymphoscintigraphy. See that. So, if a more detailed diagnostic interpretation of lymphatic channel is needed, you need to do a contrast lymphangiogram. Clear? So, for patients, very, very clearly given that when lymphoscintigraphy, see, for a patient with an edema of unknown cause, on suspicion for a lymphedema, lymphoscintigraphy is a diagnostic test of choice. When lymphoscintigraphy confirms the lymphatic drainage is delayed, the diagnosis of primary lymphedema should never be made until the neoplasia involving the regional central lymphatic drainage of the limb has been excluded by CT or MRI. Clear? Now, even more very important is lymphoscintigraphy is emerged as a test of choice for suspected patients with lymphedema. See that it cannot differentiate between primary and secondary lymphedemas. So, now you know where the question is picked up from. Clear? Line to line, word to word, Subsistent 22nd edition. So, you need to learn through that. Okay. So, you have beautiful chapters which are available line to line, page to page of decoding of 22nd edition of Subsistent Speed Learning app. Kindly go through that. A patient presented with an anterior mediastinal mass, chest x-ray showing an elevated left hemidiaphragm and shows a pleural involvement. What is the most appropriate management? What is this? What is this we are talking about? It's a mediastinal tumor. One of the most common mediastinal tumor is thymoma. Okay, thymic malignancy. So, thymoma can be benign and thymoma can be malignant. And if it is a malignant, then you do a radical thymectomy. You know the type of classification is the Mosaka classification for thymoma and the radical thymectomy. Whatever the infiltration is there, you need to remove the appropriate structures infiltrate and then you need to reconstruct the normal mediastinal structures. This is very, very important. So, the right answer should be the radical en bloc resection of mass along with the left phrenic nerve and the pleura. If this option is given, and this is the most appropriate, whether the left phrenic nerve to be salvaged, because most of the time you should not salvage the phrenic nerves. In case it is infiltrated, then you have to. Then the radical thymectomy involves like a box-like dissection. That means you go from nerve to nerve, from right phrenic to left phrenic. Yes, from the suprasternal space of Burns. From here, that means the left brachiocephalic to the diaphragm. So you go from top from left brachiocephalic vein and to below diaphragm, and right and left is up to the right and the left phrenic nerve. So that is the box-shaped dissection to the radical thymectomy. Clear? So that's what is given in the explanation in page number 1803 in Subsistent 22nd edition. That's the thymoma is used as potentially resectable, non-resectable. Resectable is to be encapsulated to be resectable, and infiltrating and neoplastic non-resectable, you should start with the neoadjuvant chemo or radiotherapy or immunotherapy, then make it resectable. Okay, then you resect, do a radical thymectomy. Clear? Yes. 75-year-old female with a high risk and irreducible rectal prolapse. The best treatment is very clear. Irreducible high risk, resect and anastomose. So the procedure is called Altimer's procedure. Altimer's procedure is resect and anastomose. Thias wiring is a localized procedure. They do a circumferential or purse string monofilament suture and place it, and once the primary offending cause is done, and you remove it. And mostly Thias wiring is done in children, not in adults. And open surgery and lap rectopexy of Wells or Repstins or Lahods. All these are done as a lap rectopexy to anchor, to fix it to the sacrum or to the rectal sling procedures or to the rectal slings. And Altimus is the most appropriate procedure for the resection and anastomosis. So you can see here very clear the Altimus procedure is a procedure of prolapsed rectum through anal canal. Full thickness, the resection is performed, and the restoration of a coloanal continuity can be performed either by stapler or Hanschmann. And this is a procedure of choice for incarcerated, see that, and strangulated prolapse. There we go. Clear? So the most appropriate for the question given here is Altimus procedure. Okay. Now, a patient presents with 3.5 centimeter a solid renal mass, asymptomatic. See, asymptomatic confined to the renal capsule. So within the capsule. What is the most? So the answer is partial nephrectomy. You know that any tumor size less than 4 centimeter and localized renal cell cancer, and it is asymptomatic, the best option could be a partial nephrectomy. Where all you do a partial nephrectomy could be the question again in RCC. The most common type of RCC is conventional clear cell. It will be either, number one will be less than 4 centimeter localized, asymptomatic and well differentiated. and or be done in a bilateral RCC, tumors in a solitary kidney, and patients with a pre-existing renal disease. So you need to consider to doing a partial nephrectomy. The other option of RCC is a radical nephrectomy. Radical nephrectomy involves removal all the structures within renal fascia, including the ipsilateral adrenal gland, and along with the en-bloc resection of nodes. Yes, en-bloc resection of nodes from where? From the diaphragm to the aortic bifurcation of para-aortic nodes and the regional lymph nodes. You have to do en-bloc dissection and send for HPE to look for the involvement of the nodes. Okay, radical nephrectomy. So here the question is about the partial nephrectomy, otherwise called nephron sparing surgery. Is it clear? Nephron sparing surgery. Great. Now, a 3-day after MI, patient with a sudden severe chest pain and has a hypotension and pansystolic one, what is the most likely cause? See, this I discussed in the brain wire session. We have brain wire session available in high yield series where we go for random topics. We start with one topic and we keep moving around the entire general surgery as the loops comes in, and that one of the loop I discussed this very, very clearly that it could be a ventricular septal rupture. The ventricular septal rupture and VSR, post-MI, VSR, pansystolic murmur. And I even discussed the treatment of choice is that double breasting, and it will be a double breasting. And also, you can also know that it is the dilatation of the anterior wall of the left ventricle. Anterior wall of the left ventricle. Ventricular septal rupture should be repaired. Treatment should be repaired. Clear? Yes. So, VSR is an important complication. So, you see that Bailey 28th edition, first reference after 20 to 30 questions discussion. 1483 Bailey 20th edition says mechanical complication of myocardial infarction, most classically VSR. This usually occurs in 3 to 7 days after MI. When infarcted myocardium becomes soft and ruptures, it can rupture in the septum, it can rupture in the anterior wall. Okay, and can present as a dilatation or aneurysmal dilatation of the anterior wall of the left ventricle. It is going to be the left ventricular or it will be the right ventricle. It will be the right ventricular circulation or right side circulation. 35-year-old male with a diffuse lobulated neck swelling and features of hypothyroidism. HPE shows ascanacy cells lining the follicles, most likely diagnosed. You see, when you look into the this is the keyword here. There could be some overlapping in HPE in all this. Because the HPE of Hashimoto's and urethral cell almost look the same. Renals can also have such kind of cells. But the most key here is the hypothyroidism. The hypothyroidism is seen only in Hashimoto's. The right answer is Hashimoto's. Because urethral cell carcinoma is euthyroid, Riedl's is hypothyroid, Graves is hyperthyroid. But when you see Riedl's, it will be a fibrosing condition. Those features are not given here. So those are fibrosing conditions, and even that can produce hypothyroidism, but those fibrosing conditions are not given here in this question. So the right answer is Hashimoto's. This is also called chronic lymphocytic thyroiditis. So cytological features, Hashimoto's thyroiditis as moderately cellular specimen and aggregates of follicular cells with an oncocytic changes. These are keywords here. So this is given in Sublistan 22nd edition, page number 932. A patient with a diffuse anterior neck swelling presents with a multiple itchy lesion over the back. Family history of thyroid cancer is present. Familial history of thyroid cancer, the most common is medullary thyroid cancer. So all this skin lesion presenting with diarrhea, amyloid deposition, and those kind of mucopolysaccharides in the skin, whether in the anterior aspect of tibia or in the back, anywhere in the body. Yes, those are the features of medullary thyroid cancer, MTC. Calcitonin is the most important biomarker, a tumor marker that you need to look for. So calcitonin gene-related peptide is one of the most important status that you need to look on. Medullary thyroid cancer is located in chromosome number 10, red proto-oncogene perisyndromic region of chromosome number 10. You need to see the point mutations involved or not, and rhesus calcitonin is there or not. If it is there, then you document MTC, and you can look for, whom be a child is going to be, when you say high risk or low risk, you look for prophylactic thyroidectomy. Prolonged intubation was done for 30 days in a 1 year, when a child 1 year back. Now he presents with a stridor dyspnea and likely diagnosis and treatment. See, it's very, very clear. So it's going to be of a history of intubation, and the patient has a stridor and dyspnea. It's a tracheal stenosis. If there is a tracheal stenosis, you need to treat it and resection of the stenosis and to correct, and then you need to anastomose. So that's what has to be done. So it's a very, very clear cut case. And symptoms of tracheal obstruction occur immediately after intubation or several years or slowly over several years, presenting with stridor, obstructive symptoms of stridor, dyspnea, and because of the obliteration of the lumen of more than 50%, and clinical signs and lung function testing are not very sensitive and specific for tracheal stenosis, standard of treatment is symptomatic patients considered for pathological resection of the that's the resection of the pathological segment of the trachea and end-to-end anastomosis. This is what it is. Clear? So this is given in Subsistent 22nd edition, page number 1779. During a ASD repair, the surgeon is trying to locate an important structure. What structure he has to locate? See, the most common type of ASD is ostium secundum, followed by ostium primum, followed by sinus venosus, followed by coronary sinus. This is the number one, right? When you are looking, the number two is ostium primum defect. Ostium primum defect will be close to the endocardial cushion. So, ostium secundum, you need to have the rim all around to close, and the ostium primum endocardial cushion defect associated with the mitral valve cleft. Could be, you need to do a mitral valve repair. But whatever the most important is in the ASD closure, you need to look on the triangle of Koch. This is called triangle of Koch. So, triangle of Koch is found by the septal leaflet of tricuspid valve and the tendon of Todaro and the valve of coronary sinus. I repeat this. Valve of coronary sinus, septal leaflet of tricuspid valve and tendon of Todaro. All these three form the triangle, boundaries of triangle of Koch, and what is sitting inside is the AV node. So, if you take a bite in an AV node, and the patient will not come out of the pump. So, that is the most important why we need to look onto this. So, any of a bite other than where you're supposed to take in cardiac surgery is very difficult to make the patient come out of the pump. Understand this. Okay. So, it is the very important, and a small of error is equivalent to death. Understand. It should be as precise as possible. Is it clear? Okay. Keep moving. So, this is what is given in the explanation in page number 1879 in 22nd edition of Subsistent. Clear? Okay. Now, fibroadenoma of a breast is an abnormality of which of the following phases of AND classification? It is the lobular proliferation. Lobular proliferation. AND is abnormal. Okay. Abnormal ANDI. Okay. So, aberration and normal development and involution. Okay. So, AND is aberration, normal development and involution. So, this is a process, physiological process that happens in a patient, but it could be pathological if it is more symptomatic. Clear? So, now when we read through that, okay, fibroadenoma is a most common cause of breast lump in women of 15 to 25 years. It arises from hyperplasia of the lobule, usually grows 2 to 3 cm in size, is surrounded by a well-defined capsule. A clinically typical fibroadenoma is confirmed by ultrasonography and may be observed with a biopsy. A biopsy should be obtained if the patient is over 25 years. If there is atypical features in ultrasonography, regression with the anti-estrogen drugs has been observed with tamoxifen and ormoxafen. So, what is asked here? A fibroadenoma. See, in a fibroadenoma, in a phase of AND, it is the lobular proliferation which is the most classical. Actually, it is hyperplasia, but the most closest answer here is the lobular proliferation in this question. Is it clear? A patient with a metastatic NET, neuroendocrine tumor, presents with the profuse watery diarrhea, flushing and occasional wheezing. He has no infective cause and is not responding to antidiarrheal medication. What is the most appropriate pharmacological agent for this patient? The most is octreotide. For any kind of NET or PNET, the most important drug we use is octreotide, somatostatin analogs. Very clear? So, with a curative intent is not possible, there is a number of locoregional therapies to the liver. Patients are always treated with somatostatin analogs to prevent the crisis. So, this is Bailey 20th edition, page number 911. Type B aortic dissection with an oliguria and hypotension, the most appropriate management will be. The most appropriate for type B is the endovascular repair. So, it is very clearly said the use of percutaneously placed endovascular stents is currently the standard intervention of choice in patients with complicated type B dissection, because it is complicated. The patient presenting with an hypotension is symptomatic, and surgery is reserved for rare cases, not suitable for stenting. See, in most of the aortic intervention, now stent has a major role. First, we try to go for a stent, non-surgical intervention. Then, if fails, then go for surgical intervention. Okay, so Stedford classification, and also about the aortic aneurysms and abdominal aortic aneurysms, and are very, very important exam areas. Diagnosis. What is the diagnosis here? We're looking at an X-ray. I mean, I don't know why an orthopedic question was asked. I don't know whether it is really asked. If it is asked, the answer is mallet finger. See, it's a mallet finger is about a loss of an active DIP extension, distal interphalangeal joint extension, due to the extensor tendon injury or avulsion fracture. The key points, mechanism is a forced flexion. Deformity is a drooping finger deformity. And to take an X-ray to rule out, splint for 6 to 8 weeks, and surgery only if the conservative fails. Selected patients. Clear? Now, which of the following immunosuppressive medication causes coronary vascular wall thickening? Coronary vascular wall thickening is caused by calcium inhibitors as a complication. Now, so this is most commonly seen in transplantation. So this is seen in transplantation because what happens is, one of the most important points you need to understand is the transplanted organ are denervated. So they typically will not present with symptoms of pain or any kind of classical cardiac chest pain or angina. So what happens is, as the symptoms are not clearly appreciated by the patient, it can keep on accumulating and the plaque size can increase and keep on thickening and undergo, and suddenly when the total occlusion comes, then they go for a classical collapse and classical presentation of a patient of coronary artery disease. So this is what is very, very important that you need to understand in a patient with immunosuppression is given mostly in a transplant individuals. This is calcium inhibitors. A trauma patient with exsanguination of hemoglobin 6 grams per deciliter present to the emergency department was given a unit of packed RBCs. He developed a transfusion reaction. It was immediately stopped. Urine examination showed hemoglobinuria, most likely cause. So this is a transfusion related, intravascular hemolysis. This is exactly. So this is a hemolytic reaction. Okay. So acute hemolytic transfusion reaction presents immediate symptoms, and hemoglobinuria is due to intravascular hemolysis, ABO incompatibility. You need to look on that. Page number 430 in Bail 20th edition. Clear? So 21-year-old neonate presents with a bilious vomiting since past 12 hours on examination. Baby is lethargic, mildly dehydrated. A plain abdominal X-ray shows a gastric bubble on the right side of the abdomen with a ground glass appearance, and the Doppler ultrasound shows whirlpool. Whirlpool sign is a classical diagnosis of malrotation. So it is a latch band dissection. Latch band procedure is a procedure of choice. So when you see the procedure, when you see the intestinal malrotation, the types of intestinal malrotation, and this is about the midgut volvulus. So in an intestinal malrotation, the C-loop of duodenum does not cross the midline, one of the key factors. Number 2, in a midgut volvulus, you see the corkscrew appearance, okay, of the contrast tapering of the duodenum. Tapering of the duodenum is the corkscrew kind of a appearance. Okay, so the C-loop of duodenum does not cross the midline in case of intestinal malrotation. So the latch band, see, you can see the picture here, the latch band, okay, that is a peritoneal attachment between the cecum. Yes, between the cecum and the retroperitoneum. Between the cecum and the retroperitoneum. So this latch band division is very important for treatment of intestinal malrotation. Is it clear? Yes. So this is all about the questions that are asked. In session 1, this is session 1. These are the questions asked, and we have session 2, 3, and 4, and 5 to discuss 25 questions per session of the recall session of NEET SS 2025 MCH surgical group questions and answer discussion. Okay, see you soon in the next discussion. Thank you. Bye-bye.